That is controlled by the lookup table.
There's like a bunch of questions on here about that, so do we need to know that?
Primarily it's controlled by the lookup table. All right, so make sure that when you're reading the question, you understand that it's, you know, there's a couple of things. One is, it's still applicable, contrast and density. You still have to see difference, right? But in as much as what controls contrast and density, that's going to be your lookup table. You still have to see the contrast and density. Because if you have no contrast, then you have all the same density and you can't make a diagnosis. So in that context, it's still applicable, but the way we get to the contrast and density and how we manipulate it as technologists is we really don't. The things that might control both of those better now than KVP, which is what we used to use to control it, would be application of lookup table, proper lookup table, and also things like collimation, and not for the same reason that it used to. Back before we had the computer algorithm, collimation could control it because the less tissue that you irradiate, the less scatter you create, and the less scatter you create, the better your contrast. But now, really, it's the lookup table and its application of the lookup table to your image. So, let's say, for example, and I was going way past what your question is, but I think it bears a little bit of understanding. Let's say that you shoot a hand on an image receptor this size, okay, and you collimate down to, you know, an area that big or even smaller. You know, let's say you collimate down to an area this size. Then you're going to have the contrast of the bones, the soft tissue, and the direct exposure, right? And you're going to have a limited amount of direct exposure, but let's say that you make the same exposure on an image receptor that size without the collimation, so that you have now, you know, the same tissues that you had before, but you've got all of this direct exposure. It kind of throws your computer algorithm into a tailspin. It thinks that you overexpose the patient. It can't really distinguish exactly what you've tried to accomplish, so it's going to take into the calculation and into the comparison between your histogram and the lookup table all of that direct exposure, and it's going to screw up your contrast and density. Okay, so the control of contrast then becomes what you've made in exposure, maybe primarily how much exposure, how much of the image receptor you exposed, and your lookup table. All right, so KVP doesn't control your contrast anymore. So KVP and contrast is no longer truly an issue. It's primarily the lookup table. Still have to see contrast, still have to have good density. It's like, I don't know what went way around it to kind of come into it and say, you still have to see. So in that context, it's still valid, but we don't really control contrast and density with technique.
I know what you mean by that. We still have to see them. Like,
We still have, okay,
Like
okay.
it doesn't have contrast.
Okay, yeah, that makes sense.
Okay, let me just bring up an X-ray. Let's see. Let's get into.
So like on the test, if the question was like what controls contrast, like in had KVP.
There's a lookup table.
Yeah. Okay.
Yeah.
Okay.
So, all right, so here's an X-ray, lateral chest X-ray. This is out of our critique class. We'll do this in the spring semester next year. All right. So when you're looking at, we'll look at this first and then we'll look at something else. Okay, so lateral chest X-ray, how we make a diagnosis is that we have to be able to see the difference in tissue type, right? So if everything on the image looked like this little spot right there, everything on the image just looked identical, we couldn't see, we couldn't make a diagnosis of it because everything looked the same. So if the patient had a bone cancer that looked just like that, then we couldn't differentiate between the bone cancer, and the lung, right? So we have to see differences in density. Density is just how dark the image is. So on this image, what we've got is direct exposure right there. It turns out very, very dark, high density, right? So even though we're shooting through, okay, so you can see just a little bit of the sternum there, but you've also got a tremendous amount of soft tissue that absorbs a lot of x-rays. All right, so you got bone and a whole lot of soft tissue on the anterior chest wall there that's absorbed almost all of the x-rays that it was exposed to. So what you have there is very, very low density. High density, low density, okay? Dark images, high density. Low density, very light images. And what we see there in the difference between those two is contrast. Contrast is difference. So we have high contrast because we have very low density, very high density, radiographic density. The contrast, the difference between those two is our contrast. Okay?
So the density is affected by a lookup table?
Yeah. Yeah. The density is primarily lookup table. Contrast especially is primarily lookup table.
So is there anything else with density?
Like with mass, if you change mass, like the question says, which factor would you change when an image demonstrates too much or too little density? Would that be mass or would that be?
I thought I changed that. Really lookup table. The only thing that too much mass or too little mass is going to affect really is your index number. Okay, so if unless you get way out of line with your exposure, right? So if you again back to the hand, if we shot a hand with 100 mass, you flooded your image receptor with so much information that it can't process it. So only if you really, really did something bad is mass going to affect your density. Same thing with KVP. Specifically with KVP, you're almost going to have way too high KVP with too much mass, right? So only in those ways are KVP or mass going to truly affect your density in a very negative way. Okay, so lookup table is really going to be what and that's your computer algorithm, is really what's going to be the controlling factor of both your contrast and your density. For example, chest x-ray, we don't want to see high contrast, so we see high contrast there, but what are we trying to make a diagnosis in? The sternum on a lateral chest x-ray? No, we're trying to look at the lungs. The problem with the lungs is we have such high tissue contrast in that we've got ribs, which are bone, and not just soft tissue, but soft tissue filled with air in the lungs, right? So if this was very high contrast throughout the entire image, then what we would see then are the ribs would be very prominent, and we'd have high contrast. So we'd have where the ribs are and where the ribs aren't. So we'd have high density where the ribs aren't, it'd be very dark, and where the ribs are, it'd be very light, right? High contrast. The problem with that is that we wouldn't be able to make a diagnosis of the lung tissue behind the ribs very well. It'd be more difficult to see it. So in a chest x-ray, what we want is low contrast. So that's what we're seeing here, is even though we have high contrast right there, that's not what we're looking at. What we're looking at is a chest x-ray in the lungs, right? So we want low contrast, we want minimal difference between the lungs and the bones, all right? So looking at the spine, granted this is an older patient, probably has a significant amount of bone loss. Most of the time the bones are going to stand out a little bit more prominently than this on a lateral chest x-ray. But this is pretty close to optimum. You want low contrast on a lateral chest x-ray. So our lookup table for a chest x-ray should give us this, right? Regardless of what KVP we use, no matter what mass we use. If we apply a chest x-ray computer algorithm to a lateral chest x-ray where we use 70 KVP, okay, KVP used to control our contrast, and the lower the KVP, the higher the contrast. Doesn't do that anymore. 70 KVP on a lateral chest x-ray on screens of films would look like a lateral T-spine, all right? But if you did that with a computer algorithm that says it's supposed to look like a lateral chest X-ray, it'll look like a lateral chest X-ray. Regardless of what KVP you used, it'd still come out looking like a lateral chest X-ray. Conversely, if we shot we wanted to see the T-spine, so we used our, you go into clinicals, you push the button that says T-spine, what you'll see is the KVP will be lower, right? So instead of 110 KVP for a lateral chest X-ray, it'll be maybe 75 KVP for a lateral T-spine. Okay, so this is a throwback to screens and films. We haven't gotten past that yet. It may be 80, 85 KVP, but it's going to be lower in a lateral T-spine or lateral chest X-ray. So the thing is, if you shot a lateral T-spine with high KVP, your computer algorithm is still going to make it look like a lateral T-spine. If though you shot a lateral chest X-ray with low KVP, the computer algorithm is still going to make it look like a lateral chest X-ray. Okay, so KVP doesn't really have that much of an effect on our contrast or our density. All right, so we're still going to have low contrast. Okay, so let me bring up something different. Let's see. Upper extremity. Let's go with. I think this was not. No, that's not exactly what I was hoping for. Let's go with AP4. Okay, so here we have high contrast. Okay, so what we've got here is you can still see tissue density differences, but the bones are much more prominent, right? So we've got direct exposure, and we've got bones, and the bones are much more prominent. Let me put these side by side so maybe you can differentiate them a little bit more. So can you kind of see a little bit the difference in contrast between these two, where the bones are standing out on the forearm, but they're not really standing out on a lateral chest X-ray. Yes. Okay. High contrast, black and white. Low contrast, just this gooey, milky looking thing, right? And this is not real pleasing to the eye, right? Just unless you're looking for a lateral chest X-ray, but that looks great, right? You can see the stuff prominently. Again, that's real pleasing to the eye, but that computer algorithm applied here would be useless. It wouldn't be completely useless. It would be not optimum. Okay? We want low contrast, we want high contrast. Computer algorithm showing us high contrast, computer algorithm showing us low contrast. Good for that, not so good for this. Okay? Controlled again by the computer algorithm, not so much KVP. When you overexpose a patient, and understand when I'm talking about overexposing, I'm talking about within a reasonable range. Let's say you used 4 masks when you should have used 2 masks on that. And test this when you go into clinicals. Find yourself something to shoot and test this. Don't just take my word for it, test it. There's always downtime at clinicals on some days somewhere. Some days in clinicals you're bored out of your mind, right? Am I lying? Some days you just wish somebody would come in so you can take an x-ray on somebody. So some days you're bored. Instead of sitting around listening to people complain all the time, go in the x-ray room and shoot something. Just take off your shoe and take an x-ray of it. Process it under chest x-ray computer algorithm, process it under a finger algorithm, and see what the differences are. Okay. Then do the same thing and use different KVP. Take note of what the KVP was, and you can phototime it to start with, and then maybe use your 15% rule and adjust KVP and see if that did anything. Shoot it over and over again with differing KVPs and mass and see if you see any difference. You won't really, unless you again really do something goofy. But if you use a different algorithm, you're going to see some differences in and your density and contrast. Okay? So again, when I say you made a mistake and you used too much mass, let's say, I'm talking about within a reasonable range. The only time I'm not is if I say something like you did something really bad. All right, so on this image, if you shot that image, you were supposed to use 2 mass and you used 4. The only indication that you're going to have that you had that you overexposed that patient is your lookup table, or I'm sorry, your index number. Your index number is going to show you that you overexposed the patient. That's it. Otherwise, the images are going to look almost identical. You would have to really, really pick it apart to tell if there was any difference between the two. And even then, you probably won't see any difference. That's the benefit of, okay, let me say this. That's the benefit and one of the biggest problems with digital imaging creation. It's a benefit because on that patient that you already overexposed, are you gonna, if the 2 images look identical, are you gonna have to go back in and repeat that image? The answer is no, you're not, right? Because if they look identical, but you know you overexposed the patient, you go back in and you repeat it with a proper technique, then what did you do? Essentially you triple dosed the patient, right? You gave them 2 doses on the first one and 1 dose on the second, you triple dosed the patient, right? So there's no point to doing that. So you make mental note that you made a mistake and you go back for the next patient, you don't make that mistake again, right? Now, the reason I say that it's a problem also is because some of your unprofessional technologists, whenever we first started using computer processing, what do you suppose they did? Intentionally overexposed patients all the time, right? So, well, I could select a technique of 2 mass. It might be good, but what if I use 2.5 mass? Could you tell any difference on the image? No. So if I use 1.5 mass, I might have to repeat it, or if it needed, let's say 2.5 mass, I might have to repeat it. But if I just go ahead and give everybody, 25%, 30%, 50% increase in dose, I'm a genius. I don't have to repeat anything, right? That's what we call dose creep. And it was a real problem when I first went to digital processing. It was a big problem. Okay? Do you see the difference in contrast and density by looking at the images? Okay, so density is just how dark the image is. High density, low density, somewhere in between. Contrast, difference in density. We can see, really white bones, really dark, direct exposure. High contrast means not a whole lot of differences. Over here, we've got a lot of different shades of gray, levels of gray. Over here, we have 1, 2, 3, 4, maybe 5. There's more than that, but that's what stands out the most. High contrast, low contrast. Can't even see the difference in tissue densities in this area, right? Long explanation, sorry, I'm long-winded. But I want to tie it all together and hopefully get you to understand it.
I also asked how to evaluate focal spot blur.
Focal spot blur, okay. You can't give me something with a yes or no answer. All right, so focal spot blur is geometric unsharpness. It's how fuzzy the image is going to be. And really, the short answer is you're looking at the edge of the structure to see if you've got any loss of sharpness or recorded detail, right? So the things that affect your focal spot blur are going to be anything that increases that fuzziness. So we tend to think of just the focal spot size as being an issue, but really it's shape of the structure, it's focal spot size, and it's OID and SID. So the short answer is you're looking at fuzziness on the image. Does the shadow look sharp, right? If the shadow looks sharp, then your focal spot blur is very minimal. If though it gets fuzzy, let's do this, because I can reach further with this. Good sharp shadow, not so sharp shadow, it's fuzzy, right?
So on the review, it asks how to calculate that.
Yeah,
Is
you're
there
not gonna have to
actual
calculate it.
calculations?
Yeah, no, you're not gonna have, there, again, there's, the bulk of the calculation on this is stuff you can do in your head. So we'll get into that later on, I just want you on the concepts right now.
Okay, sharpness and visibility.
Okay, very good. So sharpness is what I just showed you. You know, it's how well defined are the edges, right? Can you see the edges is the other thing, that is visibility. Visibility has primarily to do with fog or noise, right? So there's two types of fog. We've got that today if we get to it. But specifically what we're talking about on that is scatter radiation. The noise is scatter radiation, fog. And I'm not gonna say that fog is not an issue anymore, because it is. It's always gonna be an issue. We're gonna create scatter inside of the patient. Scatter's gonna affect the image. It's gonna lay down a layer of fog, but it's not as much of an issue as what it used to be in assessment of the image. Again, because fog, so let's ignore this one for a second and talk about this one. You can see everything in this forearm because you know, you've got high contrast, right? I'm looking for something that might help me to demonstrate this well. And actually, Meg, can you give me that that planter base? I'm going to make a mess up here. I know it. Okay, so. So this is not perfectly going to show you what I want it to show you because it's got the contour to it. Okay, when we create fog, fog is going to cover the image completely and uniformly. That's what fog is. This is fairly uniform, even though the definition of noise is random fluctuations. It's really pretty uniform with fog. You create fog and it just covers the entire image receptor. So you can see that real well, right? You can see it very well because you can see the difference in tissue types. You can see the bones stand out, and then the soft tissue a little less so. High contrast. So if I put something over it, can you still see it? Mm-hmm. You can see it, right? Is it covering it up and making it less visible? Okay. Sharpness. Visibility.
So it's just scatter?
It's scatter, yeah. So everything that has to do with sharpness has to do with lines, angles, focal spot size, okay? So that's your sharpness, is how well does that edge stop? Visibility is just that. How well can I see that sharpness? So I think I use this analogy on, what is today, Wednesday, on Friday, I guess. You wake up in the morning and you're driving to clinicals and it's a clear day. The trees are there. You can see them. You can see the leaves on the trees. You can see everything, right? And then you go on your next clinical day, you get up and the weather has changed. It's a foggy morning and you can't see the trees. Does that mean the trees aren't there? Trees are still there, right? Sharpness versus visibility. Sharpness, is it there? Visibility, can I see it? Or is there so much fog that I can't see it? The reason I say that fog isn't as much of an issue as what it used to be is because unless you really shoot through something that creates a ridiculous amount of fog, a computer algorithm is still at work to give you a high contrast image, right? So you still have a very high contrast image, even though you've got fog on the image, and the image processing and the image receptors can disregard some of that fog. Okay, you've heard of digital grids. Okay, if you haven't, we'll talk about it probably on the fourth test. But digital grids work to disregard some of those low energy photons that would add nothing of benefit to our final product in the image. Okay, so is visibility still an issue? Yeah, and it's still testable. Has everything to do with fog, scatter radiation. Is it is the lack of visibility as visible as what it used to be? And the answer is no, it's not. We can still drag out that contrast, the high contrast, even in the presence of a lot of fog, scatter radiation. Okay.
So mass doesn't affect sharpness.
Mass can affect
Can,
sharpness.
okay.
It can in two ways. Really in one way, but one direct way and one kind of peripheral way. If you use a very high MA station, you can increase the space charge, right? Which is going to give you blooming of the space charge. If you get blooming of the space charge, then what you get, let me bring this up. I think I might have drawn this out somewhere. I'll put it in this guy's abdomen. So when you have blooming of the space charge, what you've got are electrons, ideal space charge, no bigger than the filament size. But with blooming, what happens is that we've got, I won't say completely uncontrolled, but they're kind of past the filament. So when we apply the KVP, what we want are the electrons to be focused to the focal track itself, right? The focal track. So what we want is impact just on a specific portion of the anode, but when we have blooming, when they travel across the tube, we've got so many electrons, all negatively charged, they're trying to push each other apart, then they might impact somewhere else. And if that happens, then effectively we have an increase in focal spot size. Increase in focal spot size, we get a decrease in sharpness or recorded detail, right? So that's high MA stations. But also we talked about long prep times leading to blooming of the space charge. So that's not really high mass. It's kind of secondary to it, right? Because it's heating of the filament as well. But specifically, high MA stations can even without the long prep times, high MA stations can still give us that.
Visibility, KVP affects that too, right? 'Cause it affects-
Right. So anything that could increase the amount of scatter radiation striking the image receptor can affect visibility. Okay,
That
so
doesn't affect sharpness, KVP?
no, KVP has no effect on sharpness, recorded detail, just visibility because of scatter radiation. Well, I know there's got to be something else. It's like a 7-page long review.
Yeah.
Even though it's, over and over again, there's, what
It
you got?
says when you collimate, is a change in technique required?
Yes, it is. All right, so back to our, let me mute this. Back to our, I don't want to mute. Our hand, marker's going dead. Let's say it's not a hand, let's say it's chest X-ray. Let's say, better still, it's an abdomen. Yeah, let's say it's an abdomen. So we shoot an abdomen on a patient. What's in the abdomen? What type of tissue? Primarily. soft tissue, right? So what type of tissue creates more scatter radiation? Huh? Go ahead. Soft tissue, right, soft tissue. So we're gonna create a lot of scatter radiation with soft tissue. Now, if we're shooting a, any technique, let's say 80 kVp at, I don't know, 25 mass. Not an overly large patient, but our computer algorithm, our lookup table is gonna take all that data into consideration in creating, the image, right? So all of that exposure goes into creating the image, including that scatter radiation. So some of the scatter radiation is going to be on the final product. Even if we use a grid, even if we use virtual grid, some of that scatter is going to go into creation of that image. So we took, that was an abdomen, and now let's say we collimate down and we're just gonna shoot L-spine, okay? How much scatter radiation do we eliminate from the final product by collimating down just to the L-spine? A lot, right? So it's a lot of scatter radiation that we removed. That scatter radiation went into the calculation of what our image should look like, even though it was bad, bad signal, it's still signal that went into the calculation of what that should look like. So if we remove that, and again, you can test this in clinicals. I'll tell you the requirements to really test this. But if we remove all that, then what's going to happen if we use the same technique? Underexposed. It's going to be underexposed because we're going to remove some of that exposure from the image receptor when we collimate, right? We're going to remove some of that from the image receptor. So as a result, if we want the same exposure through the spine, we're going to have to increase our technique. And it's going to be really pretty subtle, so it's probably going to be 28 to 30 mass, no more than that really. But it's going to be more. So you can test this also in clinicals. And what you're going to need for this, to test this, is to kind of create a patient. So if you take your, pick something. You take a pencil and you make it or a pen, let's say the pen will have metal in it. But if you make an exposure just on the pen without collimation, and then you make another exposure on the pen with collimation, how much scatter are you going to create in the pen? Because that's what this difference is the difference in scatter radiation hitting the image receptor. How much scatter are you going to create in a pen? Much? No. How much soft tissue, how much fat do you have in your pen? None, right? So what you're going to have to do is you're going to have to take something and create a person out of it. So take you like a basin of water, right? One of those big square basins of water. You can fill it up to, let's say, half full, and then put something in there to simulate the bone. Pick something. You can take anything that you can find, and stick it inside the basin or even just on top of it, so it doesn't get wet. But make the exposure on that with the collimators open, then collimate down. And what you're going to look at here is, if you phototime and look at what your technique difference is, it's going to be lower with the uncollimated image than what it will be with collimated image. Okay, because it's counting to make the photocells get to the proper radiation dose. It's counting those scattered photons as well as good photons. Okay. So as you cut, that's again a long walk to get to yes. Yeah, as you collimate, you need to increase your technique. Drastically, no. If you phototime, then what do you have to do? Trick question? Nothing, because your phototimers take care of it. You just have to select the right phototimers, right?
to increase contrast, like besides KVP, it can be done by filtration or generator type?
Okay, I thought I edited some of that out. Used to, yes.
Okay.
Now, no. The only thing that filtration or collimation possibly, generator type, you said, filtration generator type. The only thing that those are gonna really do is affect your index number.
So IR exposure?
Our exposure,
Okay.
yeah. So everywhere that you see density as it relates to image creation and manipulation, substitute that for our exposure. You know, because that's really what density has become, is our exposure. Okay, so our exposure equals density. That's just the exposure to the image receptor. The formulation of your index number. Contrast is just straight up computer algorithm.
Radiographic quality, is that different than beam quality? Or-
Yes, yeah, vastly different. Yeah, so radiographic quality, let's bring these back up. So radiographic quality, the things that we want to see on an image, are dependent on the type of image that we're creating, right? So for extremity work, what we want to see is high contrast. And that's kind of the patent stock answer for image quality. What we want to see is we want to see adequate density and we want to see high contrast. Even though we don't have high contrast over here, we still have to see contrast. We have to see good contrast. So maybe substitute good for high, right? So this is good contrast for lateral chest X-ray. So what we want is good sharpness of recorded detail and good contrast. That's image quality. So what affects your beam quality is anything that either increases the peak or increases the average. So high beam quality, high KVP. That's what we use to control beam quality, is KVP. But other things, your filtration and your machine phase also affect it. So machine phase, 3-phase, and a highly filtered beam are higher quality than single phase non-filtered beam, right? But you don't change those. So what we use to control beam quality is KVP. Beam quality, we have to have penetration, right? So equate penetration to quality. We have to have penetration. If we used 10 KVP for this, we don't get through the patient. So if we don't get through the patient, we don't see an X-ray image. We don't see his lungs. Useless. 110 KVP, we're going to get through it. Right? So we have to have high enough KVP to penetrate. So KVP controls it. Is what we use to control quality.
But if you increase KVP, would that decrease radiographic quality? Does it fall?
Theoretically, and it always did with screens and films. So there was an inverse relationship there, but what controls your contrast now? Computer, right. So, and I must say this for the next 5 semesters, because KVP doesn't really affect your image quality anymore, 4.5 semesters, okay? 4.5, right, is what you got left? Yeah. I think Shelby doesn't like the idea of being here for another 4.5 semesters. So since KVP doesn't affect your image quality anymore, I really expect an increase in KVP, because there's no reason not to use higher KVP. Are you stuck on 4.5 semesters? Is that what we're doing?
No,
Okay.
I am stuck on radiographic. So KVP, yes, you increase KVP, but you also increase scatter, correct?
Yeah.
Okay.
Right.
Does that not affect quality of the image itself?
You would think, and that's still, visibility is still testable, right? But so sometimes you got a difference between theory and practice, right? Theoretically, as you increase your KVP, you create more scatter radiation. It could interfere with visibility, but in practice, no, it does not. It does not, unless you use 300 KVP on a lateral chest x-ray is gonna reduce your, visibility possibly, but where's your 300 kVp setting on your, and I'm using hyperbole here, but where's your 300 kVp setting on your machine? You ain't got one, right? So within a diagnostic range, kVp is really not gonna have fundamentally any effect on your visibility.
So if that
And
was
this is, let me just say that. This is why this is so hard to get, is because we still have to talk about concepts that don't really apply anymore. Okay? KVP creates scatter. Scatter potentially interferes with visibility. Oh, it does. Right?
So if that was a testable question, like KVP is increased, would it affect your visibility? You put no, and that would be the correct answer.
Well, okay, so
That's what I'm worried about. Exactly.
what's the answer to the question?
Yeah.
First off, I don't think I get any questions like that.
Okay.
I've got to do a final edit on the test, but I might
swear.
I might ask about KVP and scatter creation, right? But the actual image,
Yeah.
yeah, I'm not going to do that to you. Okay.
Perfect.
But that's why this is so tough. When we first started going to computer, and it'll eventually, come down to computer fixes it being the whole lecture for this. But sometimes the literature doesn't catch up with the technology. Sometimes even if the literature is caught up with the technology, sometimes the testing is years behind. Like they just updated the registry like 2 years ago. There's almost no use of CR systems anymore, but they just got rid of CR on the registry like 2 years ago. Just got.
How much of a change in KVP is needed to affect any noticeable change in IR? Is that the 15%?
That's
Or
the 5%.
Okay.
Yeah, 5%. Yeah, 15% is to double the exposure.
Okay, so 5.
So for the 5%, that's only for IR exposure.
Yeah,
15%.
yeah. Yeah. So what's that really going to do to your contrast?
Noticeable.
Nothing. Right? Nothing.
I just think you're making things up now at this point. I'm not sure you
probably
actually know
am.
what you're talking about.
I'm not going to say that I've never made something up.
So on the test, is it gonna say like the computer tools, or are we gonna have to
It's
pick like
computer magic.
density is controlled by mass, or is there gonna be like a lookup?
Yeah.
tool?
No, what I'm going to try to do is I've got to edit the test because poor Amy, she's giving the test on Friday because I got to be somewhere else. But what I'm going to try to do is I'm going to go back through it, and I did look at it as I was editing the review. But I'm going to go back through it. I'm going to look at it again and make sure that I don't have something that's kind of ambiguous like that. So what you're going to be looking at are things like if you needed to increase exposure using KVP, if you needed to increase exposure using mass, what would you do? If you needed to maintain the exposure, but you needed to reduce patient exposure, that would be your 15% rule, increase KVP, reduce mass. Something like that. So what would affect your image receptor exposure? Not so much density and contrast, because density and contrast is going to be computer lookup table, right? Tissue types, which tissue type is going to create more scatter radiation, which is going to have a higher incidence of photoelectric, those sort of things. What else? Bernice, you had something a minute ago, and then we went off on a rabbit trail. What you got?
I was just gonna ask if we can go over additive and constructive again for pathology.
Yeah, sure. And I don't know if my computer's back up, but where you have additive pathologies, what you have are pathologies that effectively add tissue density. right? So let's say we've got healthy lung versus pleural effusion, okay? So even though the pleural effusion doesn't necessarily, it's in the pleural cavity and it's covering the lung up, probably compressing the lung. What we've done is we've replaced air with fluid, so it adds tissue density. So anytime that we've got an additive condition, I won't say anytime, but a lot of times when we have an additive condition, we need to increase our technique. And so this is another one. Increase technique so that we can have adequate image receptor exposure. So if we have an additive condition, our usual answer on test is we need to increase our technique by 30 to 50% mass, right? So there are conditions that we might need to increase KVP. Those would be if we have significant increase in bone tissue, or if we're using casting material that absorbs a lot of x-rays. Plaster, just so you know, plaster adds a lot of tissue density, even though it's on the outside, we're going to kind of consider it tissue density. So you might need to increase KVP for application of plaster cast. And it's significant. It's like 10 kVp, 15% even potentially. But fiberglass, you don't. Dry fiberglass, you don't need to adjust your technique at all. You're going to feel of it. You're going to think, this is hard. It's going to be hard for the x-rays to get through. X-rays go through it pretty easily. It's going to cast an artifact. You're going to see it, but it doesn't absorb enough x-rays that you need to increase your technique once it's dry. Okay, so additive would be plaster cast. Pleural effusion, osteopetrosis, where we've got a increase in bone. Subtractive would be anything that would reduce patient density. And if we didn't do anything with our technique, we would overexpose the image receptor. So things like osteoporosis, pneumothorax, negative, right? Put contrast into the patient, additive. Unless you use a negative contrast, like an air, right? And then it would be subtractive.
So for tissue thickness, we use mass or KVP?
Mass.
Only time we use KVP is bone and
Right.
cast?
Or bones, cast, or barium. So, yeah. So barium, very high KVP, 100, 110, 100 baseline, really. But almost everything pathology-wise is going to be manipulation of mass. Even where we have subtractive, you can use mass.
Even if it's bone?
Even if it's bone, yeah. So you can file that, that little nugget away that you can use KVP, but from a practical standpoint, you can use mass.
IR exposure doesn't change with focal spot size change.
It should not,
Okay.
because your tube output shouldn't change.
Mm-hmm.
Then your IR exposure shouldn't change, patient exposure shouldn't change. As long as your machine is calibrated properly, there should be no difference between large and small focal spot, with the one exception that, some of your, or all of your machines not gonna let you make an exposure, with high MA on a little small focal spot. But that's exposure limited. That means you're not gonna be able to make an exposure, so.
And with generators, if we don't do anything to technique, it will go up, and patient dose will go down.
No, anything that's going to give you a higher dose to the image receptor is going to give you a higher dose to the patient. So it depends on which way you're going. If you go from single phase to 3-phase, then dose is going to go up if you don't adjust anything, right? And it's going to go up by roughly factor 2. If you go from 3-phase to single phase, it's going to go down roughly about factor 2. So walking back through that in the opposite direction, if you go from single phase to 3-phase, then and you want to maintain the exposure, then you need to do what with your technique? decrease your technique, right? So single phase, three phase, decrease technique. If you go from three phase, single phase, then you need to increase your technique by factor of 2.
And it would be like mass.
Yeah, mass. Yeah, don't double your KVP. Okay, so what else? Is that all of it? I'll say we're not going to get into new material today.
We don't need anything new.
Yeah.
What about math on the test? Like, is it gonna be, it's just, I mean, I know there's probably a inverse square law and a direct square law, but aside from that, should we spend any time studying math equations?
No, not really. You know, you might look over them, be able to identify, you know, like focus spot blur from a description, you know, but in as much as working on inverse square law, direct square law, I think that there are some, you know, math questions on that, and I throw that out there as math questions, but you know how it works. If you increase your distance, intensity goes down. That's the inverse square law. I double my distance, it goes down by a factor of 4. So you should be able to work them out in your head. Yeah, just as long as you don't, you know, swap the increase distance and you decrease your technique because you know, yeah. Just make sure you don't turn those around. Apply the direct square law where the inverse square law should be applied. Okay. Is that it? Put that down so we'll stop fidgeting with it.
Whenever we're adjusting for like the pathology and patient size, like we said earlier, like we mainly use mass, but like whenever like density or radiopacity is brought into it, that's like, I'm trying to think of like a testable question, like say like bone is brought into it, you might use KVP.
Yeah.
Okay.
Yeah.
The thickness of a patient, that affects sharpness too?
Potentially it could. Yeah, I'm glad you brought that up because of where the specific tissue that you're looking for can be found, right? So let's say, again, sometimes I can't remember which class I discussed this with, but let me get this up. So let's say we're looking for a kidney stone on a patient. Patient's going to CT, but you know, maybe you're looking for a kidney stone on a patient. So kidneys are found roughly 1/3 of the way through the patient's body. So, you know, you take a measurement of the patient, let's say they measure 21 centimeters. The kidneys are roughly 7 centimeters to the patient. So you got a patient that measures 21 centimeters, okay, from here to here. The kidneys are roughly 1/3 of the way through. Roughly 1/3 of the way through. Okay? So let's say now you've got another patient who measures 30 centimeters. So the 30 centimeters, the same holds true. The kidneys are 1/3 of the way through the patient, right? So now the kidneys are here, roughly. So what changed if our image receptor is in the same spot, we're shooting in the same room? What changed? If we're looking for a kidney stone within the kidney, what changed? OID. So as we increase OID, what happens? Sharpness recorded detail
Goes down.
decreases, right? So, yes, patient thickness can affect our sharpness recorded detail. It can also, though, affect our, air quotes, visibility. Why is that? What's this guy going to create more of? Scatter. Right.
So what's the better one to pick? Just both? It affects both of them, like sharpness and visibility.
I don't think I'm going to give you both of them, but you know, if I'm looking for sharpness, I'm just going to ask about sharpness. Most of the time, those type of questions though are going to have to do with scatter radiation. If you have a hypersthenic patient versus a asthenic patient, what are you gonna have more of? Scatter radiation, hypersthenic.
So would you wanna change your technique for that, or would you wanna do something with your SID to compensate for that?
Almost always technique. That's a good question too. Can we use SID? Yeah, we could, but what we would have to do in this case is lower our SID, which is just gonna make it worse, right? Because we're gonna lose so many photons inside of this patient that to reintroduce the photons using the SID, we'd have to decrease the SID, which would mess up our sharpness of recorded detail even worse. So if we increased our SID, could we overcome some loss of sharpness? I think that's probably where you were going with that. Answer is yeah, but then we would have to increase our technique, not just because of the patient thickness, but also because of the increase in SID. So we'd have to apply, not just technique change for the increase in thickness, but we'd have to apply the square law. Okay. So, but to finish, to bring this all the way around, what would we want to adjust specifically? Technique-wise, what would we want? Mass. Why not KVP? Produce more scatter. We already got a patient that produces more scatter. We don't want to increase KVP to produce more scatter in a tissue that we're going to produce more scatter. Right? So almost universally, our technique adjustment, unless we want to change our differential absorption, if we want to increase our penetration, then almost universally your technique change is going to be mass.
Okay. If we increase KVP only by 15%, we are doubling IR exposure.
Correct.
What are we doing to patient dose? Are we doubling that as well?
Very good question. This is getting more into sophomore imaging, but no is the answer.
It's dependent on the tissue that we're trying to go through?
In part, but let's say we've got the same patient and we use a specific KVP. To make it easy, we use 100 KVP. Patient's going to absorb less than if we use 115 KVP. That's a 15% change, right? Mm-hmm. Our image receptor exposure is going to double, but the patient exposure is not going to completely double because we're going to have an increase in penetration with this one. Okay? The penetration, we're going to have less absorption inside the patient. It's going to penetrate more. So this is going to double our image receptor exposure without doubling our patient exposure. Is our patient exposure going to go up with that? Yeah, it's going to go up pretty drastically. I'm just going to throw a number out there. It doesn't mean anything. It's just a number easy to hang on to, but our patient dose may go up by 80%. Okay, so our patient dose might go up by 80%. Our image receptor dose goes up by 100%. Okay, now let's say we want to use our KVP to reduce patient exposure. If I increase to 100, now we're going to introduce mass. Let's say we had 5 mass here. If we wanted the same image receptor exposure, I increase my KVP by 15%. Now I'm shooting with 115 KVP. Patient dose goes up by 80%. But I want the same image receptor exposure, then what could I do? Half the mass, cut the mass in half, so now we're at 2.5 mass. Just increasing our KVP made our our patient exposure go up by 80%, but if I cut my mass in half, then how much of a change do we have? The primary thing that we consider in calculation of patient dose is going to be mass. So we had 5 mass, gave us a specific exposure.
So 40?
40%, right? So 40% is where we're at. So in that way, did our patient dose decrease even as we had an increase in KVP? And the answer is yeah. That's how it is that we're gonna reduce patient dose by using higher KVP, lower mass values. Just increase KVP, increase patient dose. Increase KVP by 15%, reduce mass by factor of 2, then patient dose goes down. Okay?
But not by half?
But not by half, right. So our overall patient dose in this case is probably gonna be, I don't know, it may be reduced by maybe 20%, something like that. Overall reduction by about 20%. Is that significant? No. If you're pregnant and you have to have an AP of the L spine, is that significant to you? Probably so, right? So, yeah.
Then that's about 30%, 50%.
I don't know.
Yeah, what else?
I don't know.
If y'all are done, I'm done.
I don't know.
It's okay.